So, good evening, everyone, and good evening, sir, dear Professor Arjuna de Silva. I'm Chaunaka Disanayaka for the Apprentice Journal, Faculty of Medicine, University of Kelaniya. So, we'll be doing a short discussion, a question and answer session on COVID-19. And we have some pre-sent questions regarding the topic, which we'll be discussing first. And if anyone in the audience has any more questions, you can ask away. Is that okay, sir?
Right. Yeah, that's fine. So first of all, so this audience are final years or mixture?
This is a mixture, sir. There's outside students as well, sir.
Right. So first thing in a thing like this is, you must declare that I will definitely answer most of the questions, but you must declare that since this is at a scientific level, that I am not a virologist, I am not a immune, at least infectious disease specialist. However, I do treat COVID patients and I have experience in this. So that's important that you disclose that you can't be an expert on everything. However, rationally, you can assess most of the questions and I can guide you all if you want to find a detailed answer, right? So let's start the discussion with that. It's very, very important when you're a professional to really clearly define your limits, because otherwise, you should not answer everything when no one knows everything, obviously. Right, so let's proceed.
Okay, sir. The first question we received is, there has been a lot of information revealed on transmission of COVID regarding the possibility of airborne transmission or the duration of survival on surfaces and so on. Could you explain a bit on the above?
Right, so long time ago, there is a quotation saying, if you forget history, you will be forced to relive it, right? That's important. Because if you go back to the 1918 flu pandemic, that from that we can learn a lot, right? So this was the airborne transmission was there even at that point. That's why they wore masks. But unfortunately, WHO took a long time to decide on the mask because they thought there will be a scarcity. However, you can't take scientific decisions on what is available. All science should be science, and availability is a different issue. WHO can't change science because there is no mask. So definitely this was airborne. Generally, droplets less than 5 microns get airborne. More than 5 microns will go as droplets, right? So the main more and more evidence is coming that the main source of this, at least main, is airborne. There's a lot of even the evidence epidemiologically also that it is airborne, especially if you take the super spreader events. One of the best documented ones is in a church in Korea, where about 75 people were infected by a single person. So singing in a close environment, that's the worst place, right? So it is definitely airborne. What about other surfaces? Now, at the initial part, when people knew that they were cleaning their groceries, people didn't want to go into pools. So basically, airborne is the main thing, and droplets, obviously, right? So if you're very close to a person, droplet infection will be there, but airborne is a major component. Then hard surfaces like metal surfaces, basically. Door handles, the virus is supposed to last up to about a week, right? Other surfaces like cardboard, it's less. However, formites, these are called formites. Formite transmission is 1 in 10,000, right? So it's very rare. It's relatively rare, but that doesn't mean, so probably out of all those, I mean, though we wear all these PPE, ultimately the most important thing is a mask and our hands, because hands reason is we touch our face with them. So if you don't touch, you can't touch your nose with your hair unless you have very long hair. So therefore, fomites 1 in 10,000. That is the thing they give now, right? So that is the important thing. But it can be, the virus can be detected even for up to a week or even more, but roughly week, ballpark figures, week. So that's important. That will be the thing. So that's why once it's airborne, it will be remaining there for about 1 to 3 hours. So depending on the virus type. So the British variant, or now it's known as Alpha, no? Yes. So that can stay, or B117 will stay in the air for longer, right? So it is more infective in that sense. So that's why it's very, very important to wear mask, and that you don't wear masks with valves. When you wear a mask with a valve, that valve is a exit valve. So that's why it's easier to breathe. Those masks are not medical masks. Those are for people who are painting and things like that, for usage, for things like that, commercial usage. So that mask, though it will keep the wearer free, it won't keep the people outside free, because you just release the virus to the environment. So that's why most countries have banned these masks, but unfortunately our country has still not banned that. So we have asked for a ban for those masks with valves. So that's important point. So does that answer that question?
I think so that answers the question. I think we can move to the next question. The second one, the virus is a coronavirus with non-segmented, which is an unsegmented virus, and also known to show such diversity like the influenza virus. Even previous strains like SARS coronavirus 1 and MERS coronavirus did not show such ability to mutate. What has changed with the emergence of COVID-19 that shows such propensity to mutate?
Right. So now, as I said, I am not a virologist, but listening to Professor Malik Piris and reading about this, what I can postulate, right? The reason, now we don't know the origin of this virus. So there are various conspiracy theories. It was a militarized virus for biological warfare. We don't know the answer to that. No one knows that as yet. Probably only the Chinese will know that. However, the important thing here is that all viruses mutate, because viruses keep on reproducing. The more you reproduce, the more there is chance of something going wrong there. So if it is a thing suitable for the virus reproduction, it will remain. That's how evolution has gone on. So that is basic science. However, this pandemic has gone on for almost 1.5 years. So the virus has been multiplying for obviously longer than the SARS and other epidemics. This is a true pandemic. After 100 years, we are having a true pandemic. So it is most likely that by the sheer volume of reproduction of the virus, there are so many mutants, right? So that is the explanation I can offer. But if you need something more, we'll have to ask. But even Professor Malik Piris, I listen to many of his talks, and that's probably the explanation he gives.
All right, thank you, sir. And how has COVID-19 and its presentation evolved with the emergence of new strains and mutations? We have seen that some patients rapidly progress to even pneumonia, which were not seen earlier. What can we expect in the future?
Yeah, so these variants are very disturbing. for many reasons. Now we have seen in the first wave, practically we saw that it was like a joke. You get COVID, nothing happens. 80%, almost 80% was asymptomatic. And even people who got, we had a cluster in Valisara, the most young fit people, they had absolutely nothing wrong with it, right? So these mutations, most of them, not all, but most of them happen in the spike protein. If you look at the virus, there is a spike protein, which is the binding site. So when the spike protein opens out, like a flower, when it opens out, it can bind easily to the AC2 receptor. So therefore, most of these mutations are in that region. So when it binds easy, it's more infective, right? So then you need a less concentration of viruses to cause more damage, and it can bind. So that's why with the B117 or the initial variant, which is called the UK variant, now it's called Alpha. So that caused this, the disease is actually much more infective. We can see that practically. In addition, it seems more virulent as well because of the infectivity. And we can see that because it, instead of staying in the nasal passage, it goes into the respiratory thing much sooner. So mutations are absolute concern. So the only way around these mutations is to get herd immunity, and actually then the virus hopefully will naturally die out. But because mutations, so now South African variant, the AstraZeneca or Covishield vaccine doesn't work. We'll discuss that later. Doesn't work well. So there are a lot of issues there. So that is where we stand there.
Thank you, sir. It is said that the coronavirus has a special affinity towards angiotensin converting enzyme receptors, and that it binds to those receptors in the lungs mainly, but it gives complications related to a lot of systems.
Correct.
What is the pathophysiology behind it?
The pathophysiology. Yeah, so that is of course a detailed thing, but we'll give the basic outline. So it binds in the respiratory passages, but there are a lot of receptors. Basically, AC inhibitor, AC receptors are all over, but even in the gut you get. So that's why they get diarrhea as well. But you can, in the lungs, obviously have most. So the primary thing, it comes to the nasal passages, then goes to the lungs. So once the virus goes in, it starts to replicate. And naturally, there is an immune response, and then there is how they become like in dengue. These viral illnesses, they cause a cytokine storm. So that means a huge release of various cytokines. So this cytokine storm is the thing that damages the tissues, and in this case, the lung. And then once the lung damages, if the damage is so severe, then the patient will not recover, but otherwise the patient recovers. So all you have to do is tide through this cytokine storm or reduce the cytokine storm. We talk about, that's how a drug called tocilizumab, IL-6 inhibitor, has been shown to work. There are some questions we can later on they have asked, so we can talk about this. So that is the way we, that is the pathophysiology simplified. So this will go into detail, but basically this is what happens. So that is the cytokine storm, which releases so many cytokines, which includes obviously IL-6 as well, because this is working for it. So that is the thing that damages the tissues.
Thank you, sir. Could you explain the long-term consequences of COVID, sometimes also termed as long COVID syndrome?
Yeah, so long COVID syndrome, we have seen few patients. So sometimes it's not only related to the lung, but like post-viral fatigue syndrome, most virus things can give chronic sequelae. However, here the lung damage. So lung damage is very interesting. So because we have seen the CTs, first the X-ray, but you have HRCT is the thing you can really see the lung beautifully. So what happens is you get this ground glass appearance. Remember that you don't get effusions. That's so if you have effusions or productive cough, that's not COVID, right? So having said that, like nothing is 100%, but generally almost 99% of the time, if it's you get a dry cough, loss of smell, sore throat, so the cough is dry, it's not productive. And when you look at the X-ray, it's like diffuse opacities. It's called ground glass. It can go to crazy pavement when you get the septa. And then some will proceed to organizing pneumonia, where you can see fibrous bands, mainly in the basals initially, but mid zones also can be involved, but generally not the apicales. So this ground glass appearance, then crazy paving, and organizing pneumonia. Organizing pneumonia, you get fibrous bands, you can get focal bronchiectasis, all that. So people who go into organizing pneumonia, that's going to, it was in the past called cryptogenic organizing pneumonia. Here we know the cause. So it's called organizing pneumonia that end up in fibrotic lung disease. So once you get fibrotic lung disease, then you'll be oxygen dependent. So that will be there, but in various, so many symptoms have been fatigue, all those I said, chronic fatigue syndrome. But if you take the primary thing, that is going to be the lung involved, chronic. We have seen patients like that as well, especially in the elderly.
Thank you, sir. In the question lineups, that's the questions we've received regarding pathophysiology and the disease itself. I think we have a question from the audience. Is post-COVID syndrome the same as long COVID? Or can you comment on this?
Yeah, as far as I know, it's the same. I don't know if there is a difference, but as I said, the lung involvement post long COVID syndrome has a lot of symptoms, so I think it is basically the same. But though in addition to respiratory, there are so many symptoms, depression, all those, fatigue, chronic fatigue, all those will be there.
Are there any questions regarding the disease or the pathophysiology? You can send in into the chat or unmute yourself and ask. If not, we can move to the next big question. Okay, as we go along, you can ask questions. So the next question is, in the ward setting, how can we identify or suspect COVID patient? And as a house officer, what would be the ideal course of action we should follow?
Yeah, so I think that's one of the best questions I've seen so far. So first thing is, as a house officer, now all of us are vaccinated with 2 doses, right? First thing is, if possible, get your antibody levels checked, right? Because that's important that you have, especially neutralizing antibodies. So then the other thing is, never underestimate the virus. So even if you are vaccinated with 2 doses, always wear a mask. And remember, in a pandemic, there are no emergencies. That's the number one. If you forget this whole talk, or not talk, actually, this webinar, remember that in a pandemic, there are no emergencies, right? There are no emergencies. That means, first, look after yourself before you look after others, right? So don't rush to do a resuscitation without proper protection. Number one, right? That you shouldn't. In the airline industry, it's well illustrated. When the oxygen masks come down, you first put your mask on, right? Then you put the children or whoever is next to you. Because if you pass out, there's no one left to help you, right? Or help that person also. So number one is take protection always, even though you have accident, everything. Then history is very, very important. Like in any illness, the beauty of medicine is how sophisticated we are. Still the basics will always be important, right? So history is always important. The patient has been in contact. This is a pandemic. Patient with fever and cough, yes, think of it. As I said, dry cough, loss of smell, right? But they can come with diarrhea. They can come with different symptoms, just myalgia. So always high degree of suspicion when you're in a pandemic situation, right? So that's very important. So as soon as you identify a patient, so make sure you isolate that patient, move that patient away from the other patients, right? And then once you do that, make sure that before that you should be secure, and then check on the other people and then order the relevant tests and proceed like that. So, but the take home message is there are no emergencies in a pandemic.
Thank you, sir. Let us
Sir?
Yes.
Sir, is there any way, currently do we have any facilities in Sri Lanka to check our antibodies level?
Yes, yes. The only place, it's like this. Private sector is doing for different vaccines. Currently how the best place to check is Sri Jayawardhanapura Professor Neelika is doing a research on it. So generally she is doing it, right? You can do normal antibodies if you can't do neutralizing. That's better than nothing, right? But neutralizing antibodies are specific for the spike protein, which is the most important. Of course, there are T-cell tests you can do, but those are not necessary because the defense is not only antibodies. Long term, it's activated T-cells, memory T-cells, which will recognize the virus and start the immune cascade. So, answer your question, Javadhan.
So is the test open for the public or for selected people?
No, it's you have to pay for it, but it's open, yes.
Thank you, sir.
Right.
Our next question is, can you comment on the admission and discharge criteria for COVID patients currently?
Yeah, so admission criteria and discharge criteria, admission and treatment criteria is a quite advanced document which has come out very recently. Discharge criteria was a 2020 October circular. Right? This other one is very recent circular, treatment, revised one. So basically, if you have symptoms, you should be hospitalized. That's important. So then you can be divided into mild, moderate, or severe, depending on your oxygen saturation. So if the saturation is below 94, and with oxygen, if it's below, that's moderate. If it's below 90 with oxygen, that is severe. And plus, if you are going on oxygen, otherwise the criteria is that plus lung signs. Lung signs, respiratory rate more than 30, hypertension, all those features, and chest X-ray infiltrates more than 50%. So that criteria is quite detailed. It is given in the ministry. You can access that online. So to comment on the first treatment, I think there are FDA-approved treatment for symptomatic patients in hospital, right? So FDA has approved remdesivir. However, Remdesivir is an antiviral drug. The WHO has not endorsed it. And recent evidence shows that remdesivir does not affect mortality, it just reduces hospital stay. So it's an expensive drug. So most people are moving away from it other than the US, right? Obviously. So that's one. Then convalescent plasma. That's an important thing. Convalescent plasma is using plasma of patients who have recovered, who have a high antibody titer. You can give that to patients. So that the large meta-analysis said that that is not useful. However, within 3 days, giving that early may have some benefit, and the fact is in our setup, it's cheap and we can easily have it. So it's worth trying early. Obviously late there is no thing, and a large meta-analysis didn't show any benefit. Then if you get tocilizumab again, large meta-analysis didn't show a lot of benefit, but if it's given at the correct stage, that means during the cytokine storm. So what is important in this is ferritin. Ferritin is one marker, inflammatory marker that rises during this. And procalcitonin is normal. Procalcitonin is a marker for bacterial infection. So secondary infection is a possibility in this, but it's not that common. So what you do is the procalcitonin is normal and the ferritin, CRP are going up. That is the time to give, and there are bilateral chest infiltrates, that is the time to give tocilizumab. So it's given 8 milligrams per kg dose. You can repeat the dose within 12 hours. It is very expensive. We have been using it and it has been very effective, I say, depending on the stage. So even the trial editorial in the New England Journal mentioned that even though there is no big benefit in mortality in that if it's given at the correct time, it definitely works, right? So then there is antibodies. Developed a combination antibody. Again, FDA approved, that's not available here. But basic, the patients, obviously, they need oxygen. So oxygen delivery, there are various systems of delivering oxygen. One is via normal face mask, right? The other is using a venturi mask, where you can actually control the percentage of oxygen. Then, so you can go from 60, 40 percentage. The other thing is a oxygen mask with a reservoir, that is called a non-rebreathable mask. So there is a reservoir that supplies. So that way you can give almost 100%. Then you have CPAP, where there is continuous positive airway pressure, or BiPAP, where you give a pressure as well and you can control the oxygen. And then you have high flow nasal oxygen, right? So high flow nasal oxygen does not give high pressure, but it's a huge amount of oxygen is given and you can give up to 100% oxygen. So high flow nasal cannula, again, that's again a good method, but you need very, very large volumes of oxygen for a patient. So that's why there are oxygen shortages and things like that. So scope of this is not enough to discuss this in detail, but there is a very good document out, and they have mentioned about ECMO, or extracorporeal membrane oxygenation, that unfortunately is available only in Karapitiya. In the entire country, there is not available even in the private sector. So when the blood pressure drops, we'll say due to myocardial infarction, you can use a balloon pump. But when the lungs become stiff, there is nothing to bypass that. So if the lungs recover, sometimes you need to wait just to lungs recover. So then that's where ECMO comes in. In countries that have this, they are using that extensively as a last resort. So the other thing is ventilation, and prone ventilation is better. But once you get to ventilation, invasive ventilation, basically what they advise is non-invasive ventilation. Once you get to invasive ventilation, it's not that successful. Then in addition, using unfractionated or fractionated heparin again is important. So that is also used on patients. So initial symptomatic, asymptomatic patients obviously can be managed at home. Symptomatic patients begin in the hospital, and depending on the classification, you manage them. Severe disease is an issue. Then discharge criteria, that's a whole circular. So that says asymptomatic patients 14 days after PCR, you can discharge without a PCR, because the rationale behind that is after 10 days of infection, generally you don't have, you are not infective, right? That is accepted around the world. So they have gone up to 14, but and there is no, even though PCR may be positive, there is no active virus there, because PCR doesn't have to have a live virus to give a positivity. It's just a fragment of RNA, it will be still positive. So if you want to prove that there is live virus, you should do a virus culture. So especially people who have had these things sometimes have gone on for 3 months, we have been positive. So in the past, when we didn't know about this, we were keeping people in hospital for long periods. So this, but if they have symptomatic disease, and if it's severe disease, then they ask for, they have to be obviously asymptomatic for at least 3 days after 14 days. Everything is after 14 days. Then asymptomatic for 3 days, and then either 2 negative PCRs 24 hours apart, or IgG antibodies, right? So this is not neutralizing, just normal antibodies against the virus. So that's the criteria that's there. So that circular is also available. Those are the 2 circulars that will answer your question in detail.
Thank you very much, sir. That actually answers a lot of questions that were forwarded to us. Just to clarify, someone has asked whether, yes, someone has asked on what grounds the clinical decision to use tocilizumab would be this.
Yeah, so that's again defined in the guidelines. It is, first one is a multidisciplinary decision. So I can't come on my own and decide. So I need the chest physician. If there is an intensivist, we have to talk with him. It is an expensive drug. It's like at least 1.5 to 2 lakhs. So you can't, so multidisciplinary team is number one. Then you have to show that there is, the procalcitonin is normal. So that there is no bacterial infection. Then you have to show that the inflammatory markers are going up. And then the chest X-ray also has to show that, and the clinical condition. So all those criteria have to be there before. So basically it's a clinical decision, but taken by a multidisciplinary team and not an individual.
Thank you, sir. There's 2 more questions in the chat. Let me read them. Dexamethasone is recommended for treatment of moderate and above disease. This is correct for the immune phase rather than the. How about methylprednisolone in the viral phase and immune phase?
Yes, so if dexamethasone, sorry, I didn't mention that from the recovery trial, dexamethasone IV or oral, depending on the patient's condition, in hospitalized patients who are hypoxic, right, on air. And then if you can't, then you can use methylprednisolone. And then methylprednisolone has another place for when they have organizing pneumonia. that is later on in the disease, after 14 days or so, then you can use either prednisolone oral or pulse methylprednisolone, right? So it has a place in both phases. But this is for symptomatic in-hospital patients. That's how the recovery trial was. Also, I have to add that, sorry, I have to add two more things. On patients who are not hospitalized, they have done a trial that budesonide, this is actually not a trial, it's a retrospective study. Budesonide, 800 milligrams twice a day can prevent hospital admission, right? And colchicine, the latest trial, colchicine given early, again, these are patients that are not hospitalized. Colchicine and budesonide can be given early.
The next question that was sent to us right now was, why is prone position better, and can it be used in other pneumonia patients as well?
Yeah, so there again, that's a sort of an aesthetic question, but I'll give you the basic thing for that. Again, if you work from your basics, you can give an answer to a lot of things. So here, as I said, the APCs are not affected generally. So when you put them prone, then there is more chance of they are going to their oxygenation is better. So the rest of the lung may be like solid. So you have to get the air where the part of the lung that is working. So prone ventilation has been used before, but in this particular epidemic or pandemic, it was used because for that reason, because the APCs are generally spared. Then, having said that, once you come to ventilation, basically that's, especially in our setup, the patient survival rate is very, very low.
Sir,
Okay.
Yes.
So we see patients who have recovered from COVID getting their PCRs positive again. Is it because, like you said, that the PCR gets around months to get cleared, or can they be infected with another strain of COVID virus as well?
Yeah, that can happen if there is, especially if it's a mutant. But current guidelines, local guidelines say that after you have had COVID, you don't need a PCR up to 3 months. Even if you are asymptomatic for 3 months, even if you are symptomatic within the first 2 weeks, you won't get if you are not immunocompromised. So most likely it is what I said it is. So if you want to, if you are not sure, you can actually do a viral culture. So that's a gold standard. But otherwise, if the patient's X-ray has improved completely, and then again it reappears and you're sure it's not a secondary bacterial infection, then of course you may be a reinfection, but with a mutant. If it's an immunocompetent patient, immunocompromised patient, of course, is a different matter.
So, is there any protection for the other strains from the previous strains if the patient was infected once?
Yeah, so that's a difficult question to answer, but definitely if you can answer it using the vaccine analogy. The vaccine also protects against most of the strains, but we'll say, for instance, if you take the AstraZeneca vaccine, the B117 or the British variant, it protects about 76%. So there is basically more than 50% is the protection with the WHO calls the vaccine working. So again, symptomatic disease. Again, severe disease, almost, again, the vaccines are working 100%, but against variants, it's much less.
Thank you, sir.
We have another question.
Yes, is there?
So briefly enlighten on the upcoming issue with mucormycosis infection on COVID patients in Sri Lanka.
Yeah, so mucormycosis has been around for a long time, and if it's immunocompromised patient or you're using a lot of antibiotics, there possibilities there. But as far as I know, why it has happened it has been isolated from cow urine in India, that they may be having a local remedy to try to do that. So in our setup, it's not common, definitely, as said, because as far we have reported a few cases, but that's not common. And mucormycosis was there around in case. So I don't think it'll be a big problem for us.
Okay, sir. We have a lot of questions directed regarding vaccination. The first question is duration of the vaccine effectiveness and any trials on this regard. Whether revaccination would be necessary as in influenza vaccination.
Yeah, so that's $1 million question which no one can answer at the moment, but definitely 1 year would be a ballpark figure, right? And this is all about money, so most likely revaccination may be needed. However, if a person has got severe disease and vaccination, probably that's maybe lifelong, maybe, yeah. No one knows the answer to this as yet. So, but basic ballpark figure 1 year.
It was seen on media that United States have reduced restrictions following mass vaccination of the population, and with the current situation in Sri Lanka, would there be an ease of restriction following vaccination of the general public? What is your opinion?
Yes, no, definitely there is only one way out of this, that is vaccination. So till you reach vaccination, and even after vaccination, normal, because the mutant issue is there, at least wearing a mask, normal measures should be always in place, like washing your hands, wearing a mask, keeping social distances. But mask, of course, can come out when you're in open areas. So that's what they're doing in the US. However, definitely the only way forward is vaccination. But you have to vaccinate at least 60% of your population to do that. So we are not going to have, that's not going to happen fast for us. So immediate restriction is not going to happen to us. But yes, now in the UK this time when our team will be going to England, cricket team, when England came to Sri Lanka, we had put all the restrictions to them because they were high-risk country, we were okay. Now the tables are turned, we are a red list country and they are opening up. So the match will be open to spectators. So they have come to that level now because they have vaccinated more than 50% of their population. So once we vaccinate the population, we will be able to have restrictions definitely, ease restrictions. That will happen.
Thank you, sir. Kavindra, would you like to direct some question?
Yes. So the next question which we have is, sir, for people who receive the first dose of AstraZeneca, will they be able to receive the second dose within the recommended period?
Yeah, so the question is that's another $1 million question. So the question is, what is the recommended period? Yes, the recommended period was 12 weeks. In Spain, they have gone up to 16, but that is not EU recommended, but they have gone up to 16 weeks. And they say 6 months is also possible, right? But all this is, so that's the beauty of science is, you can't give a hard and fast answer because we will come with evidence. But what we have at the moment is 16 weeks, yes, 6 months maybe, right? So, but to answer that, we'll have to be doing antibodies and see. So, with antibody level will definitely drop after the, this is especially after 3 months, I'm sure it's going to drop. So, the option options are, if we can't get AstraZeneca, we have to do a mix and match. So the trials at the moment, Pfizer and AstraZeneca trial is out. That showed that it works, and there are few more adverse reactions, local pain, fever, things like that. But generally it works well, right? Then there's a trial with Sputnik V and AstraZeneca, which is in Ukraine and Azerbaijan, those countries. That trial is over, but the results are not out as yet. Probably end of June, mid-July. So if that's happened, we can mix that as well. Right? So unless we get the vaccines in time, it's definitely a mix and match situation. So I think the most likely situation we can do is have a small trial on our own. I think the SLMES has recommended that. I think that would be the way forward, and to see whether which vaccine works. We already know the Pfizer works, but we have not got the Pfizer as yet. We will get Pfizer. That is okay. Or the best thing would be use AstraZeneca and Sputnik. And remember, AstraZeneca is a better vaccine for the elderly or more than 50-60 age group. While as Sputnik and Sinopharm are better for younger people. The reason for that being that the trial had more young people in that, and in the leaflet of Sputnik also they say don't give over 60. Sinopharm, of course, we are giving over, but at the moment that is the thing. So basically, elderly people, AstraZeneca, younger people, Sputnik, or Sinopharm. In our situation, Sinopharm is the way forward. Sinovac also maybe, because basic principle is if you can get a vaccine, get it. We are in the middle of a pandemic. A vaccine will protect, even a single dose will protect you at least 90% from severe illness. And depending on the vaccine, from infection as well. So with 2 doses of Sputnik, 91%. AstraZeneca, probably 70 or close to 80. So not 80, but 78. Then Sinopharm again similar, 78, that range. So that's it. Then Pfizer will be 95%. So Moderna again in that range, 2 dose. Then Johnson & Johnson and Sputnik. So Sputnik V has 2 doses, which are different now. Other doses, it's the same vial is given. Here, it's adenovirus 26 is the first dose, adenovirus 5 is the second dose. So once you give, and 3 weeks apart, but now they say 3 months is adequate. So giving, so now Sputnik Light or single dose is the same, is actually dose of Sputnik V. It's just been rebranded, that's all. And then people to get the vaccine, unless you're allergic to, if you have allergies, then of course it's a difficult decision. But anyone else, get the vaccine. If you are pregnant, now we know we have to give it. And the most highest risk are people over 60 with comorbidities. Those are the high risk groups. They have to take the vaccine. Right? They have to take the vaccine. If you're allergic, obviously you can't take the vaccine in a normal schedule. It's a case-by-case decision. Right? But if you don't have severe anaphylactic allergy, not that if you have take something, you get a little itching. That's if you have had anaphylaxis, then you can't take the vaccine. Otherwise, in the normal setting, again, it's a case by case. Otherwise, take the vaccine, pregnancy, lactation, take it.
Yeah, sir. So we have another question with regard to the complications, and the question says, can people with diabetes or hypertension develop late complications post-vaccination, or is it safe for them to have any vaccine? So that's the next question.
Current evidence, yes, they are the people who need the vaccines the most. Comorbidities, diabetes, hypertension, ischemic heart disease people, are at more risk. The death rate is much higher in them. In Sri Lanka, 73% of the patients are over 60 years, right, and have comorbidities. So yes, take it. So the problem about this vaccine-induced thrombocytopenic thrombosis. So that is mainly in the younger people, females, and associated with AstraZeneca and Johnson & Johnson. And however, it's 4 in a million. 4 in a million. Most of the medical students have had AstraZeneca. So, and as far as we know, everything has been fine. But even the UK have said now not to give the AstraZeneca to people under 30, right? So, other than that, no. I think we should, when you're giving a public health message, it has to be simple. You can't complicate things. So the message is, unless you have anaphylaxis, you get yourself vaccinated. Which vaccine? Whatever you can get your hands on.
So the next question is there any conflict between spleenectomy and the COVID-19 vaccinations?
That question, I don't know. Whether there is any conflict or whether you give it. So there will be some degree of immune suppression there. But definitely you can vaccinate. Whether you will develop antibodies is a different issue. So that I don't know the answer to that, but the rational thing would be to vaccinate and check your antibodies.
So the next question is vaccination safe during pregnancy?
Yes, it is safe in the sense all the obstetrics association in UK and Sri Lanka have advised to vaccinate because they are at a high risk, right? So you have to balance. Everything is about risk and things. So though the trials are still ongoing, the general consensus is to vaccinate in pregnancy because the risk to the mother and fetus is high in pregnancy than a normal individual. So the high risk groups are obviously immunocompromised patients, then patients who are over 60, who have multiple comorbidities, hypertension, diabetes, ischemic heart disease, cirrhosis, CKD.
So the next question is there any period recommended to get pregnant after vaccination? I guess your previous explanation.
Yeah, I think I have answered that, no? And
yes,
by the way, it does not affect your fertility, right? The reason why medical students or doctors have, or maybe professionals in Sri Lanka have a low fertility rate is because the females get married at 35, right? Where they should be having kids at 20, 25, right? So when you have kids at 35, there are issues, right? So remember, that is the biggest issue we are facing, nothing else.
The next question, sir, is cynofarm vaccine contraindicated in any neurological condition?
That, as far as I know, no. As far as I know, there is no new condition like that, as far as I know. So, not particularly Sinopharm, but none of the vaccines, as far as I know, are contraindicated like that.
Okay, sir. And we have another question that is on the mucormycosis infection among COVID patients. Sir,
Yeah.
could you briefly enlighten us on the upcoming issue?
I think we spoke about that, no? So that mucormycosis is around, has been around for a long time. It's nothing new. The fact that mainly in India, it's seen, one is the hygiene issue. Two is that cow urine they have been using, I think, they have various home remedies. So I think that the combination of that and hygiene and the climate is been the issue. I think in our case, that's not going to be a problem, though there are a few cases reported.
Thank you, sir. There's one more question regarding acute respiratory distress syndrome in COVID-19, sir. Is it actually due to thrombotic phenomena or due to sepsis?
It's not due to sepsis. It is microthrombi and cytokine storm and the damage. So microthrombi.
Okay. A few more questions. Someone wants to know the procedure if somebody suspects themselves having COVID-19 or symptoms of COVID-19. What would be the procedure to get a PCR done and get admitted?
Yeah, so the ideal situation if you are COVID positive is to get a PCR. And the ideal safest method is a drive-through PCR, because then you're not going to infect anyone else. But that if that is not available, then you should go wearing a N95 mask and to the closest place where you can get the PCR and do it. However, if you're absolutely asymptomatic and you're like sure you have it because everyone else around you has had it, you can home quarantine and see. But as soon as you get symptoms, you should go to hospital. That's the thing, because you're a medical person, you will know when you have symptoms. So even mild symptoms, I think at this stage, it's maybe worth going. But if you are absolutely, especially if you have comorbidities and if you are positive, then I think you should go to hospital in any case, or you're pregnant. But if you if you're not pregnant, you're young, you're healthy, then and you have no symptoms, then you can probably home quarantine. If you're home, you can properly home quarantine and not infect the others.
And sir, somebody is interested in knowing the rationale or the principles of someone infected with COVID-19 getting the vaccination.
Yeah, if you are infected with COVID, you're supposed to wait at least 2 weeks after to get the vaccination, because it's like getting another vaccine less than, so 2 to 3 weeks at least, like getting your second shot closer to within 1 week. If you give your second shot in 1 week, there's no point. No? So it's too soon, right? So you need a gap for at least 3 weeks, 2 to 3 weeks when you're vaccinating people. So that's how it should be when you're getting, and probably a single dose may be enough.
And sir, the next question is actually several people have asked about this. After the first dose of AstraZeneca vaccine, how protected are we? And how long will this protect?
About if you are talking about death from COVID, probably
hello everyone. Unfortunately, sir seems to be unable to join at the moment. So we'll be sending the last question that was directed to us to sir, and he'll be sending us an answer. And we right now received another question. And if you all have any other questions regarding this discussion or COVID-19, you can send in through our Facebook page. Directly contact us and we can let you know in the post we made for this discussion. We'll comment under that. And thank you everyone for joining in. Especially thanks Professor Arjuna de Silva for joining in on this discussion, and Professor Rohan Sivadana for helping us with organizing this event. Thank you, everyone. Have a good night.